Good morning. I'm going to welcome you now to session 2 on new clinical data. My job is to introduce Dr. Peter Pappas as our first speaker. Dr. Pappas obtained his MD in Vascular Surgery Fellowship at the University of Medicine and Dentistry in New Jersey, now known as Rutgers. He went on to serve as Chief of Vascular Surgery there, as well as Director of their Vascular Lab, Director of General Surgery and Vascular Surgery Residency. He was also the former past president of the American Venous Forum. He came to Center for Vein Restoration in 2016 and is now the chairman of our research department, chairman of our ABVLM board certified vein and lymphatic fellowship program. And he also is the chair of this meeting that you're seeing today. It's a lot, and I didn't even do him justice. So he's going to be speaking to you right now on MEDCAC and vein therapies in Medicare beneficiaries.
So thank you, Zoe. Let's see. There we go. So why are we here? So for those of you who don't know, the MEDCAC meeting was in 2016. So 5 years later, we're still talking about it because of the impact that that meeting had. So this diagram here is actually from the Medicare database. And what it shows is that over a 10 to 15 year period, the exponential growth that was seen in endovenous procedures in the Medicare population. And whenever CMS sees these kind of graphs with the lines going straight up, they immediately do some investigations and try to put some restrictions on the utilization of this type of therapy. So if you look at the growth, who was the major growth in? And what you see here is that the major growth was in cardiology, up 24%. The traditional physicians who utilize these therapies, vascular surgery and usually general surgery, decreased. And then there was a small increase in radiology, particular interventional radiology. So there was a review of the practice patterns that was done here also in Medicare populations that was past the 2013 use, and you can see that it still was on the increase. It's starting to flatten out a little bit, but there's still an increase in the endovenous procedures. Now, if you look at this study by Babra et al., it was a very interesting study. What the study looked at was the types of subspecialists who were performing the procedures. And again, what you find here is that vascular surgeons are about 22%, cardiologists are about 19%, general surgeons 13%, radiologists still hovering around 9%, but the other specialty groups are about 30%. They were the vast majority of the people who were performing these procedures. And then if you look at this next study, we're looking at the types of people who are performing this in the utilization index. What you see here is that there was a group of people who, about 25.6 of them, who performed more than 3 ablations per patient. And so that when you see this, this is very disturbing kind of information, given the fact that there are approximately 3% of people who are performing at least more than 3 ablations per patient, and some of them are performing even greater than 10 ablations per patient. So obviously there's concern for overutilization, but moreover, there's some concern for fraud here as well. So in 2016, the Centers for Medicare and Medicaid had a MEDCAC meeting, which stands for Medicare Evidence Development and Coverage Advisory Committee. And what they did was they asked the AHRQ, which is another agency within the government, to do a literature search looking at all of the studies regarding venous disease therapies and outcomes from the year 2000 to 2015. And the main reason was to determine whether or not a national coverage policy decision should be created, because the concern amongst the providers is that there were all these local coverage policy decisions, and a lot of them were disparate, and there was no cohesiveness to these policies. So what they did was they invited numerous luminaries and to be part of the panel, and they had these voting questions here. And so the first voting question was for adults with varicose veins and other clinical symptoms. How confident are you in the energy, in the level of evidence? And you had to grade it from 1 to 5, with 1 being low and 5 being high. There was also the same kind of question regarding the post-thrombotic syndrome and venous obstruction. And then the AHRQ divided up the discussion into diagnostic testing, treatment for lower extremity varicosities, and then treatment for chronic obstruction. And what they concluded, what the AHRQ concluded, was there was very few comparative studies regarding the existence of the current therapies compared one to the other, and that there was insufficient evidence to support or refute the use of duplex ultrasound. And that one finding prompted a great deal of discussion because most of the literature on duplex ultrasound was done before the year 2000. So many of the venous disease world was unhappy with this finding. They did find that there was sufficient evidence for mid and short-term effectiveness, but they said that there was insufficient evidence for long-term. And they also felt that the level of evidence supporting venous stenting was very, very poor. So the panelists were asked to vote on this. And you can see here that this is an article from the Journal of Vascular Surgery. And the Journal of Vascular Surgery asked members of the Society for Vascular Surgery who are experts to also employ the same voting methodology and compare it to what the MEDCAC specialists found. And what, for the most part, there was a synergy between the findings, except for in patients with symptoms with long-term. The Society for Vascular Surgery experts felt that there was sufficient evidence to support long-term effectiveness in our current therapies. So there were some things that came out of the AHRQ review and in the publications that came after the MEDCAC meeting. So one of them was that there was limited data on Medicare beneficiaries. Now remember, CMS is concerned about Medicare beneficiaries. And what they really want to know is, are these therapies they were offering as effective in their patient population? There was insufficient outcomes on data greater than 1 year. And I think that was true. In 2016, there was only 1 or 2 randomized reports that showed outcomes past 1 year. Variable use of physician and patient reported outcomes. Not all the studies used the rVCSS. Not all the studies had quality of life, and very few studies had both of them. Limited comparative outcome studies, limited data on race, which was a big concern. Interestingly, they said limited data on gender, which I found fascinating since most of the disease in venous disease is in females. And they also found that there was limited registry data that was of high quality. So in order to answer some of these questions, we at the Center for Vein Restoration decided to look into our extensive database to try to answer some of these questions. So we presented this updated study at last year's AVLS. Now, our first publication on this was in 2018, looking at about 38,000 patients. This study looked at 130,000 patients with 15,000 Medicare beneficiaries. So what we wanted to do was to update our 2018 study, which only presented outcomes on patients at 1 month. So we wanted to look at 1, 6, and 12 months. We specifically wanted to do a subgroup analysis looking at race. We wanted to add all of the information on rVCSS and CIVIQ, and we wanted to do some comparative effectiveness studies. So we divided our patients again into Medicare beneficiaries and non-Medicare beneficiaries, and we did a subgroup analysis based on patients who had ablations alone, ablations and phlebectomies, and ablations, phlebectomies, and ultrasound-guided foam. Again, so this is the largest study that's done in Medicare beneficiaries. There were 15,000 Medicare beneficiaries who had 25,000 limbs that were treated, compared to 35,000 non-Medicare beneficiaries and 53,000 limbs. What you see here is by race. This is the breakdown by age and then also within an age group. So was there 14% were African Americans, 2% Asians, 13% Hispanics, 20% who refused to designate, and about 50% were white. But when you look at them within their age groups, you see that about 27% were actually African Americans, 5% Asians, 23% Hispanics, and again, a large number who are also Caucasian. So when you look at the male to female ratio, again, it's what you would expect. There are more women to men. And when you look at the CEAP distribution, just like our earlier 2018 publication, non-Medicare beneficiaries presented with a high incidence of C1 and C2 disease, equal incidence of C3. But as you get older, the incidence of C4, 5, and 6 disease is greater in our Medicare beneficiaries. Now, when you look at the long-term results, what you see for here in this slide is that for Medicare and non-Medicare beneficiaries, there's no difference in terms of rVCSS or CIVIQ scores when they have an ablation alone. Slightly better outcomes in non-Medicare beneficiaries at 12 months, but for the most part, they're similar. When you look at ablations with phlebectomies, there's something very interesting in the data here, is that Medicare beneficiaries at 6 months had similar outcomes to non-Medicare beneficiaries at 1 and 6 months. So if you're purely looking at rVCSS scores alone, there seems to be a 6-month lag in Medicare beneficiaries. But when you look at their CIVIQ scores, the patient-reported outcomes, there is no difference in any of the time points. So I found this to be something very interesting in the data, that the rVCSS in Medicare beneficiaries lags behind the CIVIQ data. And then finally, when you look at a comparative effectiveness analysis that we did looking at thermal ablations with radiofrequency or laser compared to Varithena, because again, the MEDCAC said that there was very few comparative effectiveness data. We looked at 1 and 6 months because we felt like we didn't have enough patients at the 12-month analysis to do an appropriate analysis. So what we see here is that essentially there's no difference between thermal ablation with radiofrequency or laser or Varithena at the 1 or 6 month time points. So that was for ablations alone. Same thing when you see ablations with phlebectomies. Essentially, there's really no difference between the two technologies. So what about long-term randomized data? So again, since the 2016, there have been several studies now that have come out looking at 1 year, 3 year, and 5 year data, which is very important because in order to get a national coverage policy decision, we need randomized trials that look at long-term follow-up. So the one that's quoted the most is the Rasmussen paper, but since then we have data from Latimer, Beemans, and Brittenden. And for RFA, there is no difference in recurrence rates, reintervention, neovascularization, or recanalization compared to laser. There's a lower recurrence rate and recanalization for RFA, but the need for reoperation compared to USG was higher. For EVLT, there's no difference. Same thing, rates at 5 years compared to surgery, but there was a higher recanalization rate in EVLT and a higher neovascularization rate compared to surgery. And ultrasound-guided foam sclerotherapy had the worst outcomes. It was inferior compared to laser and surgery, 4 times higher risk of recurrence and a 2 times higher risk of reintervention. Now, this is important because our European colleagues tend to use a large amount of ultrasound-guided foam sclerotherapy. And if you look at the recent EVRA trial, close to 2/3 of the patients were treated with ultrasound-guided foam sclerotherapy. So, and then this is just some of the charts looking at reintervention rates, recurrence rates, recanalization rates. So I will refer you to this slide and the studies for your review. So in conclusion, Medicare eligible beneficiaries demonstrate improved outcomes similar to non-Medicare patients after ablations alone and ablations with phlebectomy with or without ultrasound-guided foam sclerotherapy at 1, 6, and 12 months. So this is just to show that for Medicare beneficiaries, they get the same results as non-Medicare beneficiaries, which is what's important to CMS. The randomized clinical trials that are available at 3 and 5 years demonstrate good long-term results for EVLT and RFA compared to surgery and superior results compared to ultrasound-guided foam sclerotherapy. The problem with the randomized trials that we have is that the numbers tend to be small. They have between 200 and 300 patients in the largest study and an average of 60 patients in the other study. So I'm sure we're going to need more randomized trials with longer follow-ups and larger groups in order to kind of get the information we want. And finally, ablations and phlebectomies together. There is a 6-month lag if you just look at rVCSS scores alone in Medicare beneficiaries, but the CIVIQ 20 scores did not demonstrate that lag. In the comparative effectiveness, Varithena is equally effective as thermal ablations, and the current data indicates that 25% of Medicare beneficiaries received 3 or more ablations, strongly suggesting an appropriate use. And believe me, CMS is following this. And then the new Novitas LCD reflects the results of these recent analyses. And I think Novitas's LCD is going to stand as an example for the other Medicare carriers. So thank you very much for your attention. Now, I'd like to take this opportunity to introduce Dr. Tony Gasparis. Dr. Gasparis is a professor of surgery at the Stony Brook University in the Division of Vascular Surgery. He's also the president-elect and he's going to be the president of the American Venous Forum this year. So Tony is going to talk to us about the Eschar and EVRA trials.
Thank you, Peter, and thank you, CVR, for the invitation to discuss with you guys the randomized studies that are out there on the role of treatment of superficial venous disease and venous ulcers. So really to understand, there's two trials that have been developed, the EVRA trial and the Eschar trial, and to understand the most recent one, we ought to look at the Eschar trial first. And this was the first randomized study looking at the elimination of venous reflux and ulcer healing. And it was really designed, EVRA was designed in order to address some of the criticisms and concerns that came or were evident in the Eschar trial. So when you look at patients with C6 disease, which was basically the Eschar trial, it was a prospective randomized trial. And this was back in 2004, before endovenous ablation had widespread use. And it looked at surgical treatment, high ligation and stripping, plus phlebectomy, and conservative therapy compared to compression stockings alone. There were 500 patients enrolled with C6 disease. Interestingly, 60% of the patients had isolated reflux, but there was another 40% of patients who had combination of superficial and deep venous disease. The endpoints that they looked at was ulcer healing at 2 years, as well as ulcer recurrence at 12 months. And here you can see the layout of the trial. They looked at almost 1,400 patients that were screened in order to identify the 500 patients that were enrolled. Now, when you look at, oops, this didn't come out good, but anyway, the 24 ulcer healing rate between surgery versus post-compression compared to compression alone was very similar between the two groups at 1 year, and then out to 3 years that remained the same. So there was really no difference in ulcer healing. When you look at ulcer recurrence, though, there was, you can see on the graph there, a diversion, and at 12 months, freedom from recurrence was superior in the surgical group compared to the compression group, 12% versus 28%. The 4-year freedom from recurrence was also different, 31% versus 56%. So treatment of superficial venous disease did improve ulcer recurrence and increased freedom from the 4-year freedom from recurrence ulcer rate between the two groups. So in summary, surgical correction of superficial reflux, in addition to compression bandages, does improve ulcer healing, but it reduced did not improve ulcer healing, but it did reduce ulcer recurrence at 4 years and resulted in a greater proportion of ulcer-free time. Now, compared to, so the criticism in this trial were several. When you looked at the high ligation group, patients waited a median of 7 weeks after for their operation. So they had a significant time period of compression early on. So there was a bias towards compression healing compression group compared to the surgical group. Both groups had compression, so ideally, if you really want to see what's better, you may want to randomize patients to compression versus surgery alone. And a number of patients, like I mentioned, about 40% of them had combined venous to superficial and deep reflux. The ulcer size was on the small side. On average, it was about 2 centimeters square. And there was a significant number of patients that refused surgery, about a quarter of the patients overall. Lastly, it didn't really, like most trials that have a limitation, it didn't really look at compliance for stockings. So Eschar showed a reduced rate of ulcer recurrence when you treat a superficial disease, but the effect on early treatment for reflux on ulcer healing remains unclear, as a significant number of patients waited over 7 weeks for treatment. So the EVRA trial was really developed to look specifically at ulcer healing and recurrence if you treat patients early on versus defer treatment. There were 20 centers in the UK. And you'll see that, as Peter mentioned earlier, with ulcer-guided sclera, you'll see that reference to how these patients were treated. Randomized early intervention, 226 versus deferred intervention, 224. Both groups, similar to the Eschar trial, got compression as a combination therapy. The primary endpoint was time to ulcer healing. And there was a bunch of secondary endpoints that were looked at, including rate of ulcer healing at 24 weeks, recurrence, ulcer-free interval, and quality of life indicators. Patients were randomized 1-to-1. Now, interestingly, compared to the Eschar trial, they had to look at about 1,400 patients to get 500. Here we have almost 6,500 patients, over 6,500 patients that were screened to randomize 450 patients. A little bit bigger as far as ulcer size, but still not big ulcers, 2.5 to 2.9 centimeters square, and short duration, about 3 months on average, these ulcers were present. Now again, here you can see the breakdown. There were almost 6,500 patients, 450 randomized, and about half of them into the surgical group with compression versus compression alone. And this was not limited to one single modality. I'll show you the breakdown a little bit. Demographically, the two groups, early intervention versus deferred, a little bit older population, not surprisingly, in CVD disease, given that these are patients with venous ulcers. BMI, again, not surprisingly, ulcer patients tend to have a higher BMI, but no difference between the two groups. Mostly, over 90% of them were white in race. And ulcer size, like I mentioned, 2.4 and 2.9, that was not significantly different between the two groups. Now, when you look at time to treatment in the intervention group, so this was early intervention was 1 versus deferred. And in the early intervention group, you can see the vast majority of the patients were treated within 2 to 4 weeks of randomization, compared to the deferred group, which was 4 to 6 weeks. And interestingly, about a quarter of these patients did not receive any treatment. So again, a little bit mixed group. If you're looking to compare early interventions versus deferred intervention, because a quarter of them really never got in the deferred group any intervention whatsoever. Type of treatment, about a quarter to a third and received endothermal ablation only. The vast majority, about half of them, had foam sclerotherapy alone. And then another 10% or so had a combination of endothermal and foam. Again, criticisms of this, you have versus Eschar. Eschar treated both saphenous and the varicosities. Here you see there's a diverse treatment or algorithms. In some patients, obviously, they didn't really break this down in the foam group, but was this for the varicosities alone or for saphenous and varicosities? So a very diverse group between the two, but again, no difference really as far as when you compare the two groups as far as treatment protocol. Looking at the results, time to ulcer healing significantly lower in the early intervention group, 56 days versus 86 days when you defer these patients, and 12-week healing, 63% versus 51% in the deferred group. So again, time to healing and healing overall was higher in the early intervention group. So kind of, again, breaking this down a little bit more, overall healing between the two groups, 93% at 1 year versus 85% in the deferred group. And recurrence rate, 11 versus 16%. Again, that was significantly different. Median ulcer-free time, lower in the early intervention, obviously, because they did heal quicker. So in summary, early intervention results in faster healing of venous ulcer, more time free from ulcers. And when they looked at, sorry, just go back one. When they looked at overall recurrence, time to ulcer recurrence first ulcer recurrence was no difference between the two groups, but overall ulcer recurrence was significantly lower in the early intervention group. Again, similar to the Eschar, and in retrospect, a lot of limitations in this study. Again, a lot of patients needed to be screened to get 450 patients. Smaller ulcers, although bigger than the Eschar trial, short duration of ulcers present. Variable treatment protocol that I went through, again, with more than half of the patients only receiving ultrasound-guided sclerotherapy. And as Peter mentioned, the recurrence rate of venous disease in ultrasound-guided treatment is higher compared to endothermal technologies. High percent of patients, like I said, foam, only about a third of them requiring ablation. Only 10% of patients had comprehensive superficial treatment compared to the Eschar trial where stripping and phlebectomies was done. And there was really a variable ultrasound follow-up in the two groups. And again, similar to the Eschar trial, there was really no good documentation as far as compliance with stockings, although there was no stocking arm alone. This was just looking at early intervention versus delayed. This was just published last year, looking at long-term clinical and cost effectiveness of early intervention. And they did at 4 years found reduced time to ulcer healing and more time free ulcer compared to the first paper. And you can see at 4 years, 34% versus 38% recurrence in the two arms. And although time to first ulcer recurrence was no difference, overall ulcer recurrence was significantly lower in the early intervention. And they went on to conclude that highly likely to be cost effective in the management of venous ulceration. So in summary, Eschar did not show an improvement in ulcer healing, which was the reason EVRA trial was put together. It did show a reduction in increased ulcer healing rates in the EVRA trial when they looked at it. The Eschar demonstrated improved ulcer recurrence at 5 years. And EVRA showed that if you treat these patients early on, it does improve your time to healing. And although this is wrong, although ulcer recurrence was no difference as far as the first ulcer recurrence, the overall recurrence rate in the early intervention group was lower. And they did conclude that it was cost effective, despite the fact that, like I said, it's hard to tell because half of these patients did get foam sclerotherapy, which is a much cheaper treatment modality. Thanks, Peter.
Thank you, Dr. Gasparis, for that very, very comprehensive review. I'm sure we're going to have a lot of questions for you at the question and answer session at the end of this session, but it's now my distinct pleasure to be able to introduce Dr. Pappas for the second time today. He'll be speaking right now on the effect of race on outcomes from superficial vein treatments.
So thank you, Zoe. So this topic was one of the topics that was pointed out by the MEDCAC in 2016. So this is our effort to try to determine whether or not race has any effect on outcomes. So this was one of our first papers that we've recently published last year in 2020. Let's see. Yeah, there we go. Let's go back. So our previous publication in 2020 did indicate that we did see some outcomes based on race. And we also saw this in the rVCSS and the CIVIQ scores. Furthermore, we will also determine that progressive increases in BMI are associated with worse outcomes, and Dr. Diol will talk more extensively on this in the next talk. So in response to the 2016 MEDCAC, we wanted to dive deeper into this issue of race and whether or not race had any effect on outcomes, as some of the previous publications have suggested that there were worse outcomes in African Americans, for example, for CVI treatments. So again, the AHRQ demonstrated that these were the deficiencies, and race was one of the deficiencies that was outlined. And what you see here in the San Diego vein study was this is really the first epidemiologic study that was done in a US-based population to show whether or not there was any differences in the incidence of varicosities. And here, and in this study, You see that Caucasians, again, made up about 60% of the patients, Hispanics and African Americans around 14%, and Asians 2%, which is pretty much consistent with what you're going to see in our study. This one looked at risk factors based on race and whether or not there was a difference in the severity of venous disease in men and women. And as you can see here, there is a difference in severity, especially in the Hispanic male population, with a confidence interval of or an odds ratio rather of 1.48, and in women of 1.21. So if you look at severe disease, the incidence actually, the odds ratio is more severe in Asian men at 1.5. And you'll hear later on from our data why we think that is true. And it's about similar in women for severe disease. So our hypothesis was that CVI-related treatment outcomes would differ based on race. So this was our paper that we recently published. It was a retrospective chart review expanding the years of 2015 to 2017. And we looked at these following races: African Americans, Asians, Hispanics. Again, others were people who refused to identify what race they were, and Caucasian patients. And we also looked at rVCSS and CIVIQ scores, again, to address one of the criticisms of the MEDCAC, that patient-reported outcomes and physician-reported outcomes were rarely reported together. So this was our demographics, as you can see here. The number of African Americans, Asians, Hispanics, and Caucasians. So we looked at 66,651 patients who presented during that 3-year time period. And then when we look at the number of procedures, you'll see that because the Asians were the lowest patient population, they actually had the lowest number of procedures, but for the most part, the number of procedures and limbs treated were basically similar. So if this is the total here. There were 25,000 ablations performed, 14 to 15,000 phlebectomies, and about 11,500 ultrasound guided foam sclerotherapies. So when we look at the incidence here, it's over this 3-year period, it's actually quite interesting. So the incidence actually started to decrease in African Americans from 20% to 15%. Stayed flat or decreased slightly in the Asian population. It stayed flat in the Hispanic population. Started to increase in the group that designated themselves as other, and then in the Caucasian population it increased. So for our African Americans and Asians, it started to decrease, and for our Hispanics and Caucasians, it was either flat or increasing. When you look at the prevalence by race and the prevalence by gender, again, what you would see is African Americans and Hispanics were essentially the same in terms of prevalence. And then when you look at it broken down by gender, women outnumbered men by a ratio of 3 to 1, except in one group. If you look at our Hispanic population, women outnumbered men by about 5 to 1, and our Asian population was almost identical. Now, if you look at the data regarding the incidence and prevalence of venous disease, every paper you read will say that the incidence increases as you get older. But when you look at this by race, it's actually kind of not true. So for everybody other than Caucasians, the incidence of venous disease actually decreases as you get older. And for a Caucasian, it actually increases. Now, if you look at these studies that were published that said that the incidence increases with age, it's because all of these studies were done primarily in Caucasian patients. So there's a bias inherent to these epidemiologic studies because they really didn't include large populations of African Americans, Asians, and Hispanics. So if you look at the prevalence by race again, it's very interesting that African Americans, for example, have a very high incidence of C0 disease, as do white people. Now, we interpreted this as patients who are actually presenting with like symptoms that were non-related to their venous disease. So there is a high incidence of morbid obesity and arthritis in the African American patient population. So a large percentage of these patients who are presenting to our offices have no venous disease. Hispanic patients present with a large incidence of C1 disease and C2 disease. Again, the C1 disease is very cultural in the Hispanic population, and there's a very high concern rate for C1 disease. And C2 diseases, many of our Hispanic patients are working class patients, and the varicosities are actually interfering with their ability to work. And then when you look at the incidence of severe disease, C3 or higher, it's what you would expect. There was a higher incidence in our African-American patient population and our Caucasian population. So there is a difference in presentation based upon race. Again, if you look at just African-Americans and Hispanics, you'll see the same thing, high incidence of C0 disease in African-Americans, high incidence of C2 disease and C1 disease in Hispanics, and then a very high incidence of severe disease. If you look at how the presenting symptoms, the majority of patients present with the typical symptoms of pain and aching, followed by swelling, heaviness, fatigue, cramping, and so on. Again, if you look at the presenting symptoms broken down by race, again, our African-American population has a high incidence of ulcer, skin changes, aching, swelling, and pain, consistent with the severe presentations of C3 or higher disease. Our Hispanic patients present with a very high incidence of spider veins. Cramping is a big complaint, as well as lower extremity pain. And then the very interesting finding is when you look at recommendation rates, usually for CVR, our recommendation rates are between 47 and 50%. And then the number of patients that actually go on to get a procedure is around 36%. But in our African-American patient population, that is not true. Our recommendation rates were only 34%, and only about 27% of them actually proceeded on to go ahead and get anything done. So again, this highlights the fact that African-Americans tend to present with C0 disease and issues related to their legs that are unrelated to venous disease. Now, what about some outcome data? So if you look at patients who had an ablation alone, what you see here is that if you look at the rVCSS data, and the number of procedures that were done, that Hispanics and others had required the lowest number of ablations, and Asians and Hispanics actually had the best outcomes as reported by rVCSS compared to the other patient populations. So when you look at the average number of ablations and phlebectomies, one of the interesting findings was that Asian patients required a larger number of ablations and phlebectomies, and primarily this was on the phlebectomy side for the Asians. And when we looked a little bit deeper into this, what we found was that our Asian patient population actually presented with a higher incidence of below-knee tributary disease and a higher incidence of C4A disease. So they required more ablations and phlebectomies as combined procedures compared to other groups. And again, Hispanics required fewer numbers of ablations and phlebectomies when compared to other racial groups. Outcomes were also similar in that our Hispanic patient populations had the best outcomes in terms of rVCSS scores after an ablation with a phlebectomy. And then finally, when you look at all three procedures done together, Asians required the fewest numbers of combined ablations, phlebectomies, and ultrasound-guided foam sclerotherapies. But the interesting thing is when you look at the rVCSS scores for all of the races, they're all identical. And what this really tells me is that African Americans can have the same outcomes as any other race, but they require more procedures to be done, because if you look at the average number of procedures, African Americans had the highest numbers of ablations and phlebectomies and ultrasound-guided sclerotherapy. So previous publications which indicated that African Americans may have worse outcomes, my interpretation of that is that they had more severe disease and they were undertreated. But if you're aggressive and remove all of the sources of reflux, they can achieve identical outcomes to any other racial group, including Caucasians. Now, we furthered this original paper by looking at races, again, based on age. So here in this study, we just submitted this to the Journal of Vascular Surgery for a publication. We looked at outcomes of ablations with phlebectomies and phlebectomies and USGs, and we broke them down into Medicare and non-Medicare beneficiaries. Because the number of Asians at the 12-month mark was low, we only looked at 1 and 6 month data. But what we found here is that all initial and 6 month scores within an age group were significantly different. All initial rVCSS scores between an age groups and within an age group were different, except for Asians. And all 6 month scores within a race and between groups were different, except for Asians. So if you look at ablations and phlebectomies, they're essentially similar. All 6-month scores within a race and between age groups were similar, except for slightly better results in Caucasians who were non-Medicare beneficiaries. And again, to highlight this, the MEDCAC indicated that there was not enough data with rVCSS and patient-reported outcomes. So this is only about the second paper in which rVCSS and CIVIQ scores are reported together. And then finally, when you look at all 3 procedures done together, there is essentially no difference in outcomes based on race or age group, except for, again, non-Medicare beneficiaries who were Caucasian, who seem to report better outcomes compared to the other races. So another thing that we did was we tried to look at whether or not there was a role or an effect of insurance status on this. So we know that oftentimes outcomes when you're looking at races are based on socioeconomic factors. So we wanted to see were there any differences in terms of insurance. And what we found was that in our Hispanic patient population, compared to all the other races, there was a lower incidence of Medicare beneficiaries. So Hispanics, there was only about 15% of patients, whereas in all the other races, it ranged between 26 and 30%. When you looked at commercial insurance carriers or Medicaid, there was a higher incidence of Medicaid patients who were Hispanics and a lower incidence of Blue Cross Blue Shield patients who were Hispanic. And then the other interesting factor was when you looked at the types of patients who were interested in paying out of pocket, Hispanic patients by almost a factor of 6 were more likely to pay for venous procedures out of pocket compared to all the other racial groups, indicating that there is a considerable cultural impetus towards getting some of these procedures. So finally, CVI, as we know, is primarily a disease of white women. African Americans present with a higher incidence of C0 disease more often than any other race. This may be secondary to higher BMIs and an increased incidence of osteoarthritis in this group. And as a result, they tend to have the lowest recommendation rates. Hispanic patients present with a higher incidence of C1 and C2 disease more often than any other race. And Hispanics and Asians require fewer ablations and have better rVCSS scores after an ablation alone. And Asians required more phlebectomies more often than any other racial group. And they have a higher incidence of C4 disease compared to other groups. African Americans present more often with C4, 5, and 6 disease, and more often require multiple combined procedures like ablations, phlebectomies, and ultrasound guided foam sclerotherapy to achieve the same results. And there's no difference in outcomes between Medicare and non-Medicare beneficiaries based on race, except for non-Medicare Caucasian patients who seem to demonstrate better outcomes regardless of the treatment type. And then finally, Hispanic patients had a lower rate of Medicare and Blue Cross Blue Shield coverage and a higher rate of Medicaid and self-pay, and were more willing to pay out of pocket for these procedures compared to other racial groups, indicating that there is some socioeconomic and cultural effects in terms of outcomes and treatment choices. So at this point, I'd like to thank you for your attention. I'd like to introduce Dr. Zoe Diol. Dr. Diol is a general surgeon, and she is one of our regional medical directors at the Centers for Vein Restoration. Dr. Diol, in her previous life, was a bariatric surgeon, and she has a longstanding interest in morbid obesity. And she's published one of the seminal papers on the effect on morbid obesity and treatment outcomes for venous disease. So Dr. Diol, you are up.
Thank you. My disclosures, I am on the Speakers Bureau for Tactile Medicine in Boston Scientific. I've got a lot to say, so I'm going to dive right in. Trying to get control of the screen here. Unable to advance my slide.
Yep, so if you wiggle the mouse around until you see that over the, yep, it looks like you just clicked into that area. So if you want to click again, you should be able to advance from there. Yep, perfect.
There you go. All right, so this is a map of the United States. It might remind you a little bit of our COVID maps lately, but it's not. It's the incidence of obesity in the United States. Worldwide, obesity has nearly tripled since 1975. And what the map doesn't show you is the cost. Over $150 billion is spent annually in the management of obesity. And COVID actually has had an impact on that due to quarantine, decreased activity, and poor nutrition. And the biggest impact it has had is on children. And the latest CDC reports show that 1 in 5 children in the United States between age 2 and 19 suffer from obesity. And there are racial disparities to talk about, Dr. Pappas's. The incidence of obesity in Hispanic children is 25%, African Americans is 22%, and 14.1% for Caucasian. Sorry about that. Okay, so the incidence of venous insufficiency in the United States, 150,000 new patients are diagnosed each year with venous insufficiency, and $500 million is spent in the care of those patients. So what can we extrapolate from that information? As the incidence and severity of obesity rises, also the incidence and severity of venous disease will rise. So now more than ever, it's important to understand the disease and how to properly treat it in this challenging population. There has been plenty of research demonstrating a relationship between obesity and the severity of venous insufficiency. Of particular interest to me was this study here that showed that BMI and clinical severity of venous disease was independent of reflux in 2/3 of the patient in their study, where patients with C4 and higher disease had no ultrasound evidence of reflux in their axial veins. And they posed the question as to whether BMI should be incorporated into severity scores such as the CEAP, since it seemed to be an independent risk factor for C4 to C6 changes. Our study was the first to look at the relationship of obesity to outcomes from venous insufficiency treatments. This was published in July 2020, Journal of Vascular Surgery, Venous and Lymphatic Medicine. I'll briefly review our study. We looked at 64,000 patients who underwent thermal ablation, microphlebectomy, ultrasound-guided foam sclerotherapy, a combination of those, and we stratified them based on BMI and CEAP score. We analyzed outcomes based on venous clinical severity score and also on quality of life score. Unable to advance that slide. There we go. Quality of life score using the CIVIQ 20 questionnaire. The results of our study showed that there were progressively smaller improvements in 6-month post-op venous clinical severity scores in BMIs that surpassed 35. Now, this is in CEAP class 3 patients, which is edema. However, we noticed the same results happened in CEAP class 2, 4, 5, and 6. The group with the poorest outcomes were patients with a BMI greater than 46, where there was no statistically significant improvement in 6-month post-procedure VCSS scores. And quality of life scores seemed to follow the same pattern. There was some improvement in the 1-month post-op quality of life score. However, in patients with a BMI of 31 or higher, those quality of life scores trended back to baseline. So what exactly is happening? Our conclusion was that treatment outcomes for venous disease correlate with BMI and CEAP score. There were progressively worse outcomes in BMI groups higher than 31 to 35 for patients undergoing thermal ablation alone. Now, the addition of phlebectomies did improve those results 10%. However, adding ultrasound-guided foam sclerotherapy to the phlebectomies had no additional improvement. So what's going on? The effects of obesity. What I'm going to try to break down for you here today is how it impacts these changes in severity and outcomes. We're going to look at intra-abdominal pressure, shear stress, inflammation, thrombophilia, fat distribution, lymphedema, and obesity-related skin changes. Shear stress. Obesity has, particularly actually central obesity, has increased femoral vein diameter, such as what you would see in a Valsalva maneuver. And this mimics a proximal venous outflow obstruction. Now, what you want as far as shear stress against the endothelial, you want a normal laminar flow or high shear stress. because that affects the endothelial cell morphology and function through secretion of nitric oxide, prostacyclin, TPA, and von Willebrand factor. In obesity, because of the proximal obstruction from the intra-abdominal pressure, it causes stasis and a low shear stress. So part of Virchow's triad there, where it predisposes the patient to thromboembolism with elevated fibrin and D dimer. Now, this study in particular here, I think is interesting. It shows you a control group on this side with a no abdominal pressure. They put some pressure cuffs on their abdomen here, and then they compared it to an obese population. And in this study, obese meant a BMI of 30. You'll see the vein diameter in the control group is 7.3. When you look at a BMI of 30, 8.5. You look at the shear stress down here of 2 in the normal population, and it's down to 1.6 in the patient with a BMI of 30. Now let's look at inflammation. So obesity-induced endothelial cell dysfunction is mediated by altered endothelial nitric oxide synthase, as well as sirtuin-1, increased oxidative stress, and stress on the endoplasmic reticulum, as well as a disruption in the normal autophagy. I'm going to include a word about something called microRNAs here, because you're going to be hearing more about this in some of the basic science research. But microRNAs are small particles that have a wide range of control over cellular function. They've already been implicated in cancer, diabetes, cardiovascular disease, and now what we're seeing is microRNAs also lead to endothelial cell dysfunction in obesity-induced cardiovascular disease. And we can extrapolate all of this to the venous system as well. Now, I like this slide because it pulls it all together here. So what you see is the adipose tissue. As your BMI goes up, there's going to be adipose hypertrophy, and that will cause increase in the inflammatory cytokines, causing a cytokine storm here with the monophytes and macrophages. So you have an inflammatory reaction in this person's body, leading to hypercoagulation, increase in tissue factors, also hypofibrinolysis. So promotes thrombin formation, platelet dysfunction, vasoconstriction, increase in von Willebrands and angiotensin II, and also that endothelial cell dysfunction I mentioned from the microRNAs. So this turns into a giant snowball effect, where as the BMI goes up, the inflammatory and thrombophilia goes up and up and up progressively in a spiral snowball. Now, I'm going to mention COVID here because I think you all have heard that obesity is a predisposing factor for severity of COVID. What you have is an already inflammatory and hypercoagulable state in an obese patient. You add the SARS-CoV-2 virus to that, and it is basically like adding gasoline to a fire. And all of that just accelerates that entire inflammatory process, which is why we're seeing venous thrombosis and arterial thrombosis being one of the primary causes of death in these patients. And this is just a little teeter-totter scale that I like to look at, where your body should be in a nice balance here between a pro-inflammatory condition, anti-inflammatory condition, vasoconstriction and vasodilation, whereas obesity is going to tip the scale towards this side, pro-inflammatory, vasoconstriction, and endothelial cell dysfunction. Trying to get to the next slide. There we go. All right. So now let's look at some obesity phenotypes and the differences between them. There are different phenotypes and they're not all the same. So central obesity carries a higher risk or worse vascular prognosis than peripheral obesity. And expanding on that, BMI is actually not the best measurement of obesity. It is waist to hip ratio. In 2003, I believe, Willenberg did a study where they did not look at BMI, but they looked at waist to hip ratio as a measure of obesity and factored that into the increasing waist to hip ratio did result in a higher incidence and severity of venous disease. And there are also fat disparities between men and women. Now, in general, premenopausal women do have a higher ratio than men of abdominal fat, but they carry it in the subcutaneous compartment known as SAT, or subcutaneous adipose tissue, as you see here. Men carry their weight in the visceral compartment, and that's known as VAT, visceral adipose tissue. However, as women go through menopause, you're going to see a redistribution of that fat. So they're going to redistribute from the subcutaneous compartment into the visceral compartment. Also, interestingly, with pregnancy, you're going to see women will start redistributing their fat from the subcutaneous compartment into the, that was supposed to be a video, subcutaneous compartment into the visceral compartment. With each subsequent pregnancy, that visceral deposition is going to increase and increase. And this tends to parallel the incidence of venous disease. So venous disease is more prevalent in the age 50 to 70 age group for women, which is that postmenopausal age group where they have an increase in VAT. It's also triggered by pregnancy and worse with each additional pregnancy, just like the redistribution of body fat into the visceral compartment. Now, men who have a preponderance of their body fat in the visceral compartment also have a greater incidence of C4 and higher disease and a greater incidence of deep system reflux. All right, so this slide shows you the different body fat phenotypes. The SAT phenotype, particularly the what we call pear-shaped femoral gluteal distribution, this confers protection against metabolic and cardiovascular disease, such as diabetes and coronary artery disease. And it's called the apple-shaped distribution. We can also assume this may confer protection against venous disease. Whereas the apple-shaped here, the visceral, carries a higher rate of metabolic and cardiovascular disease associated with that shape. You can also have young women. You can also have young women who carry their body fat in the central compartment or the apple-shaped configuration, and they carry the same risk of metabolic and cardiovascular disease as men and postmenopausal women. And what you're seeing here is a laparoscopic view of visceral adipose tissue during a laparoscopic bariatric Roux-en-Y bypass. And the omentum is usually very thick and heavy, and you see what looks like fat creeping around the intestines, what you would see in a Crohn's patient. And the consistency of that body fat is very different from a patient who carries it in the subcutaneous compartment, where it's more oily and soft. It's something that you have to actually see and feel to understand. Again, trying to get, okay. All right, how does lymphedema factor into this whole picture? Obesity and chronic venous insufficiency are each independent risk factors for lymphedema. The effects of chronic venous insufficiency and obesity are both additive on the development of lymphedema, so it stands to reason that clinical severity of venous insufficiency in the obese population should be higher. This lady is a patient of mine, and she has what's called phlebo-lipolymphedema. And I'm just wondering now, based on what I told you, whether you would consider treating her venous insufficiency. So in the early stages of venous insufficiency or chronic venous disease, the lymphatics are very able to accommodate and expel the interstitial fluid that builds up. However, as the disease advances and skin changes develop, that changes. And we're going to look at what the Starling principle. It used to be believed that the 90% of interstitial fluid or edema from venous disease was reabsorbed by that venous capillary, whereas 10% was absorbed by the lymphatic capillary. But now, as we're beginning to understand what the glycocalyx is, we understand that the glycocalyx in that venous capillary actually acts as an impermeable barrier and prevents reabsorption. So in reality, 100% of that interstitial fluid is reabsorbed by the lymphatic system. This is a really interesting slide that shows lymphatic uptake in comparison to the different stages of venous disease. So right here you see C2, so you've got simple varicose veins without edema in this patient. And you see what's called a nice linear pattern where you're seeing the lymphatics doing their job and taking up all that excess interstitial edema. When you start seeing edema from venous disease, you now have a damage to that lymphatic uptake. You're not seeing that nice linear pattern here. And then you enter the C4 stages where you have the skin changes and you're beginning to see insufficiency or reflux in the lymphatics, all the way over here to your C5 and 6 where you have ulcers and you're seeing severe reflux or what's called a starburst or diffuse pattern of reflux of the lymphatics around those areas. And what we now know is that the glycocalyx also plays a role in the lymphatic system and is severely disrupted, especially in obesity, and that impermeable barrier now becomes permeable. Now, this patient, when I asked you if you would consider ablation, I actually did go ahead and ablate her axial veins. And what you can see is there is a visual improvement. So here she was before with her edema, cellulitis. You can see she has improvement in her legs, but she surprisingly did not have very much improvement in her clinical severity score. She still has skin changes, she still has swelling, and she still has pain. Also, her CIVIQ 20, which was her quality of life, it changed, but not as much as you would expect based on the before and after pictures here. So what else is going on? We can look at one more thing, which are called venous microvalves. Now, I'm going to draw you back to one of my first slides where I told you about a study by Padberg where they showed that in 2/3 of their patients with C4 and higher disease had no evidence of axial vein reflux, yet those obese patients showed these skin changes. So what could be happening is that there is a complex network of small veins and tributaries that travel distally towards the dermis. And they're divided, like I said, into 6 levels. These microveins or small veins have microvalves. And where there are microvalves, there could be reflux. So this study used a resin to look at reflux in these microvalves. And what they observed were 3 important things. That valvular incompetence in these small veins of the skin can exist independently of valvular competency in the axial veins, the GSV, SSV, and the accessories. Number 2, the valves in that 3rd level are called boundary valves, which are able to prevent that reflux from extending to the skin. However, once those 3rd level valves are breached, the incidence of ulceration jumps up. So you can have GSV reflux present, but in the competency of these microvalves, especially that 3rd level, that may play a role in preventing those patients from advancing to a patient that has or develops skin changes. So the conclusions from our study were that number 1, BMI should be incorporated into discussions with patients regarding their treatment outcomes and expectations. And we also proposed that BMI needs to be incorporated into evaluation of disease severity, whether it's the rVCSS score or the CEAP score, but it does definitely play a role. Now, what I want to make very clear is that there is no hard stop on ablating veins in a patient based on their BMI. And I'll point out a few things. It's just more important to understand the disease of obesity and how it affects your patients and their insufficiency when you determine who and when to treat. So you have a patient that has a bad venous ulcer or bleeding varices, and they have a high BMI, and they have venous insufficiency. Well, they're not going to be able to get into a weight loss program unless they can increase their mobility. So in my opinion, I think treating the venous insufficiency to aid with ulcer healing, which Dr. Gasparis mentioned, it will speed ulcer healing, is one way to get that patient back into mobility, exercise, and weight loss. And I want to compare, we don't hold or withhold treatments on obese patients when they have coronary artery disease or peripheral arterial disease, or even smoking for that matter. We treat those patients, but we have to educate them and then encourage them to lose weight and to quit smoking in order to prevent recurrence. I'm going to wind up with this one last presentation because it's dramatic. It's from my colleague, Dr. Evan Harris. This was one of his patients. This lady came in with a BMI of 56. She was housebound. She had recurrent ulceration. She was hospitalized at least twice for cellulitis. She had bilateral leg GSV and SSV insufficiency. And as you can see here, she's got a diagnosis of phlebolymphodema. So based on my talk, you might say, oh, I don't think we should treat this lady. It's not going to be successful. Well, he did treat her. And this is her before and after. And you can see there is a dramatic difference here. And I'm going to go through the numbers for you and how he reached that result. All right. Her original CEAP score was 6 in both legs. Her VCSS 21 and 19 in the right and left, respectively. Her CIVIQ 20 was 89. She weighed 310 pounds and she had a BMI of 56. He treated her insufficiency and he also prescribed home compression pumps for her lymphedema. He prescribed short stretch Velcro wraps like I did in my patient. 8 months later, she's down to 270 pounds. She put herself in a medical weight loss and exercise program. She became very motivated. Her BMI is now 49. Her VCSS did improve, in fact, but her CIVIQ 20, the quality of life, is not much different at 80 versus 89. So there are other factors in play here with these quality of life scores. And so you've got to look at your patient, and I'm going to wind up with this last slide that I think it's very important. The obese population is just not straightforward. They're highly complex. You can't ablate a vein and then let that patient go and expect to see great results. You're going to have to incorporate proper wound care, lymphedema therapy, weight loss programs, and appropriate compression stockings or wraps or pumps in order to see great outcomes. And that requires a multidisciplinary approach to care. So I hope I've covered that well for you. And it looks like we're going to head now into our question and answer panel. I'm sorry for going over. And we'll bring in Dr. Peter Pappas to answer questions on his talks, as well as Dr. Antonio Gasperis to answer questions on his talks.
So thank you, Zoe. That was a great review of that. It's also one of the first talks I've ever heard where someone described the pathophysiology behind why BMI is affecting some of our treatment outcomes. So before I let you go, Zoe, can you discuss a little bit about what you think about the rVCSS and whether or not we should consider updating the rVCSS to include BMI as in terms of our treatment outcomes? Because that last slide that you showed of that phlebolymphodema patient was certainly remarkable.
Absolutely. I really do, because I think that this is going to promote better quality care of our patients. You've got to address the obesity. You have to address the lymphedema. You can't just address venous disease. We've even changed the name of our society from the American College of Phlebology to the American Vein and Lymphatic Society. This is one disease process, and BMI is a big, or obesity is a big impact on both of those disease processes. So I believe very, very strongly that we do have to incorporate it into the VCSS score. And that will also encourage, I think, our treating physicians to address those issues and not just leave it as a simple vein ablation, which is just a small part of that healing process.
So Zoe, we've got a lot of questions from the audience regarding this topic. So LaTanya Bingham asked, would it be more beneficial to educate as well as give the patient time to lose weight before treatment, just as we recommend compression for a certain amount of time before intravenous therapies? So what do you think? Should we wait?
Yes and no. And here's how I say that. It has to do with how severe their disease is. If I have a patient who's got a very large BMI, no skin changes at this point, I am gonna wait. I'm gonna put that patient in a weight loss program. I'm gonna educate them on the reason I'm doing that because of the outcomes of their treatments, and I'm gonna see them back. I'm not gonna let them go. I'm gonna continually bring them back. Now, if I have a patient who's got pre-ulcerative changes or active ulcers, or like I said, bleeding varices, I'm going to educate them but I'm going to go ahead and treat that person first. And then I'm going to simultaneously treat them with the pumps. And once I get an ulcer to heal, I'm going to then send them on to the weight loss program and the lymphedema therapy program, and then definitely follow up on them and never lose track of them so I can document their BMI and document the recanalization rates of the treatments. If they are headed down that weight loss path and they're doing an excellent job and they do need an additional treatment, I'm happy to do that. But if they're not putting in their effort that they need to maintain the good results, as long as I can keep them ulcer free, I'm not going to retreat that venous problem.
So a corollary question that was asked by Gloria is this: I understand that BMI is something that needs to be put into consideration, but how do you talk to your patient without making them feel bad about themselves to let them understand the outcomes will be better if they lose weight?
That's a delicate process, and I learned how to do that when I was a bariatric surgeon. I basically just explained to them that I know that they want the best results. I know that they want to increase their mobility because I know they want to become healthier. So I put it into the, I know you want to succeed. So this is how we're going to do it. And then I just outlined this plan for them. It gives them power. You want to empower them with giving them the tools. And once they feel like you know what their issue is and you're going to help them and you're going to give them the tools, they get really motivated. So you want to inspire them rather than accusing them or blaming them. Never blame. So just clearly outline hey, this is the way to success, and I'm going to help you do it, and let's get started.
So Tony, there's two questions for you. So along this same path, do you incorporate discussions about BMI into your treatment outcomes? If you do, what do you tell your patients? And one of the questions from the audience was in regards to the EVRA trial. Barbara, I'm going to butcher this.
Yeah, I saw that, Peter, but
Yeah.
why so many patients, 25%
the
of the
deferred group
patients
didn't get therapy.
didn't
Yes,
get therapy.
could you just expand upon that and answer the question about BMI in your practice?
Yeah, so I mean, similar, to any other trial, at some point there's a percentage of patients that refuse therapy. In the Eschar trial, I think it was a similar number, about 23%. EVRA had, again, about 24% of patients. Of the 50% that were enrolled into the delayed treatment arm that did not have therapy. But regardless, when they looked at outcomes, it was an intent to treat. So those patients were incorporated in both studies as far as whether they were, when they looked at outcomes. So it kind of skews the data in the delayed treatment in the delayed treatment arm when a quarter of them did not receive any therapy. But that's with any, obviously, trial. Now, as far as the BMI, yeah, I mean, that's a very tough question. And we all know when you look at venous disease, there's no one single thing, only a small number of patients, and usually the ones with C2 disease, that it's saphenous vein is the offender. In the more advanced stages of patients, usually you have a percentage of patients that have either deep reflux, proximal obstruction, calf muscle pump dysfunction, obesity, whatever it is, phlebolymphodema. We know that CVI is multifactorial. And obviously, when you have a big problem in the obesity side, that is something that you need to address and discuss with the patients as far as expectations for outcomes. And when you have the patient with more advanced disease, like Zori said, those are the ones that I would offer treatment, understanding that, that's not going to cure their problem. Unless they address the underlying obesity at some point. Unfortunately, I mean, in my experience, and maybe I just don't, I'm not convincing enough to patients. It's very hard to get these patients to, because they have other medical issues with their obesity, right? They have diabetes, they have potentially coronary disease if they're older population. So, if they're not willing to address the obesity for serious medical issues, it's hard to get them to do it for venous disease, unless they have like a venous ulcer, and that's really affecting their quality of life.
So I think Dr. Diol and Dr. Kasparis bring up 2 points that I want to emphasize here a little bit. So for the morbidly obese patients, just like any of our other venous disease patients, the discussions about setting expectations. So what Dr. Diol's paper indicates is that we should be talking to these morbidly obese patients about expected outcomes and tell them that they may not get the same outcomes as someone who is not as heavy. The second thing is, if you have to decide for yourself, are you going to incorporate this into your practice in counseling morbidly obese patients? And what I've decided to do is I've reached out into my community, and I found, I tried to partner with a metabolic weight loss center and a general surgeon or a bariatric surgeon. And what I found is that when you broach the discussion by offering them non-surgical options and you send them to a metabolic weight loss center and tell them that they're going to get a coach and a counselor, that they tend to be more open to the discussion and increase the likelihood that they're going to participate in this, because every one of them tells me in the office, look, doc, I try to lose weight, no matter what I do, it doesn't work. And then what I tell them is that, well, you can't do it by yourself. And I even use myself as an example, because at one point I got a little heavy and I couldn't do it on my own. And I had to go to one of these centers and I lost 40 pounds with the assistance of a coach. So, and there are many other, like there are apps now that help you do this stuff. So I think if you're going to have this discussion with the patient, you need to offer them some solutions and to be kind of like an encourager or a coach, but they need to know that their outcomes may not be as good as other outcomes.
So Peter, let me ask, and you, Zoe, when you do have that discussion with the morbidly obese patient, what percentage of them actually follow up? Because we have actually, where our vascular center is right next door, is we have a metabolic weight loss center. And I'll talk to them about it, and I will send them over there, provide them even information. What percentage in your experience do they actually follow up?
Well, I usually do the same thing, refer to a center, and I give them, since we do routine follow-ups at 3 months, 6 months, 1 year, I give them a progressive goal, of what I want their BMI to be at their next visit. And that usually gives them an extra motivation to get there. So as far as following up with the weight loss programs that we direct them to, I can't be 100% sure that they're doing that, but I do see these patients losing weight, on their follow-up visits when you get them treated. But I'll let Peter respond to that too, but I'm going to respond to a question here from Andrea Silver. Have you noticed a higher thrombotic complication in patients with higher BMIs? Do you put them on a more aggressive ambulation schedule or prophylactic anticoagulation? I don't there is obviously BMI or obesity is a risk factor for venous thromboembolism. I have not anecdotally noticed the increased incidence of EHITs or EFITs in these patients that we treat. A good thing to maybe possibly look at in another study, but I do not put them on prophylactic anticoagulation for treatment. Now, I don't offer or prescribe a more aggressive ambulation schedule. I'm pretty aggressive in educating all my patients on the importance of ambulation to prevent DVT, but I don't know if anybody has anything different. But Dr. Gasparis, I'm going to pose a question to you, and then I'll let Dr. Pappas take it over there. But based on your studies and your review of the EVRA and Eschar trial, you have a patient, I'm just going to pose non-obese, comes to you with a 6 centimeter venous ulcer with refluxing GSV and a refluxing perforator, has never been to wound care. What's your steps of management?
So we're pretty aggressive. So we schedule them for treatment. Obviously local wound care, compression, and then get them approved for ablation or whatever they need. So
you treat immediately and then simultaneously do their wound care?
Yeah, we don't wait for their ulcer to heal.
Okay.
Unless there's a active infection or anything, but we're pretty aggressive, and then we don't routinely go after the perforators. I usually prefer to treat the underlying ulcer bed with foam sclerotherapy. A lot of times, if you do that, you may knock out the perforator as well, unless it's a huge perforator or if I'm doing foam sclerotherapy in the bed and I see that it's not closing the varicosities, then it's telling me the significant reflux in that perforator that's preventing treatment of the ulcer bed.
So I'm going to ask that we end the discussion here. So just to quickly answer Dr. Gasparis' question, only about 4 or 5% of my patients actually go through at the time.
Yeah, that's
But it's
what
not-
I mean. That's what I found.
Zero.
I would say about 10% of the patients, and then maybe a handful of my patients actually have had bariatric surgery.
Yeah.
Um,
So I'm going to thank the panelists for this this session. It was very informative. Obviously, there's a lot of interest regarding the issue of DNI and outcomes, and we're going to move on to the next part of the program. I'd like to take this opportunity to introduce the Center for Vein Restoration CEO and founder, Dr. Sanjiv Lakhanpal, and he's going to give us an update as to what's going on at CVR and where the future lies for us. So, Dr. Lakhanpal.
Thank you, Peter. Can I have my slide, please? While we're waiting for the slides to come, guys, this is amazing. If you look at the quality of the discussions, the quality of the presentations that Peter has put together, that all of our CVR colleagues are presenting, all of our invited guests are presenting, this is, for me, this is like a dream come true. And I hope every one of you feels that passion here. You know, every little thing that we can do to advance our science, right? The next generation may come and say, hey, this was not, you know, what you guys came up with was wrong, but there's something else that's right. But as long as we have done a little bit to advance science, we've really taken our responsibility very, very seriously. So with that, I still don't have my first slide. Yeah, great. So can I move it here? No.
Yep, if you want to just click into that area, you'll be able to control from there. Looks like you're, yep, good to go. Thanks.
Great, thank you, thank you. So just to set the scene a little, guys, since this is a virtual meeting, I think a lot of you otherwise see one another. We have a hall full of people here, and thank you very much for taking the time to be here. And about 1/3 are CVR team members, about 1/3 are other colleagues from the vein and lymphatic societies, and about 1/3 are people who trust us with their referrals, people in the primary care world, who generally we respectfully call them as referring physicians. So I will tailor my talk accordingly. And to start off, I'm going to address folks from CVR, Team CVR. Taking a deep breath. This is, we just got our 100th center. It's with Dr. Calcagno and Rossi trusting us and becoming our partners. We have reached a landmark, a milestone of 100 centers. And, you know, just reminisce, those of you who've been, so I was just looking at the numbers yesterday, about 40 of you have been with us for over 10 years. And your average age for this subset of people is 40 years. That means a quarter of your life you have committed and dedicated to your CVR. At a personal level, at a level of all of the senior leadership, we just cannot express enough gratitude for all of you for having done that. Now, as we reminisce through our journey here, I'd like to bring a couple of things forward as to how did we get here? What all has every one of you sacrificed to get here? And first and foremost, the thought comes is that as we have evolved, you see those, you know, CVR logos as we've gone through the years. And you know, for some people, it might be, hey, you can't even make up your mind on your logo. But the reality is this shows our evolution to what you're seeing today, what Peter has, you know, put forth in front of everybody today, starting from a single center. And, you know, if I can think of all the people who were there at that time, the Bobs, the Namios, the Joannas, the Zaids, who helped us go up, Gordon from the call center, Ken, he joined us right after that, that we have all evolved as professionals, as I would love to say, as human beings as well. We've all come from being doers to becoming managers. And you all put up with that. I mean, that was not an easy process. From becoming an actor to a director is a very complex process, as we've all learned the hard way. And not just that, folks who were supporting you also let you evolve, let you go through that process. And that's what the number 100 denotes to us. It's, to say otherwise, okay, 100 is just a number, but this also tells us that you all decided to walk together. That old saying that if you want to walk fast, walk alone, and if you want to walk together, you will walk far. That is why we've gotten to 100. And otherwise, you could have 2 or 3 centers which are really generating a lot of good stuff for the patients, but at the same time, to get to this milestone, to get to this landmark, it clearly tells me and tells everybody else that you guys have really been great team members. And to my physician partners here, we, especially with the interventional, with the surgical mindset, it's very easy for us to think that healthcare is all about physicians. But the fact that we've hit this number of 100, it is also because you all realize that you may be the tip of the spear, but there are equally important engines that have to work to support what we all do. And that's what really makes a healthcare practice into a healthcare enterprise. So it's all those things that have led to a huge achievement that you all have, and this is just something we found out a couple of days ago, that CVR was awarded not just a healthcare industry top workplace award, but also a top workplace USA award. And again, goes back to gratitude, goes back to thanking every one of Team CVR members. And this is through 2020, through the pandemic year, that you guys have given yourself and us this great gift. And then if you look at what all you've identified on the screen as things that make CVR good for you, challenging. It's imagine a team that is turned on by professional challenges, a team that really values diversity of thought, inclusiveness, hard work. You would think that a lot of people, and this is across all generations, as we have people who are, baby boomers, the Gen Zs, the Gen Xs, everyone. And, there's all these things that the young people don't know how to work hard. But look at this. And as we spread this out between age groups, it is the younger people who really liked the challenges and liked the fact that we make them work hard. So this is absolutely the foundation of something. When I first saw the number 100, the thought came, oh my God, it's 100 years. And then you realize, oh, no, we're not that old. But someday, if we continue the same spirit that you all have shown to come here, I assure you, it's venous insufficiency is not going anywhere. There's no, tablet or drug that's going to come that's going to solve these issues. It's our future together is very, very bright, guys. Thank you for all that you've done here. Now, let's focus a little bit towards folks who may be new to CVR, who don't know CVR that well. What has all this teamwork translated into? What has that led to? And as a healthcare enterprise, the first thing we got to talk about is clinical outcomes and clinical utilizations. These are our numbers. As Peter also showed, that we recommend treatment to about 50% of the patients, and then at the end of the day, about 30 to 35%, depending on what clinic you're in, end up getting their treatment because there are certain other barriers we got to cross, like insurances and compression stockings and all that stuff. So we are so proud of that if 50% of our patients, and most of our patients are referred to us by you guys, if we find that, hey, the issue may be somewhere else, we're really doing this right. And then the average number of ablations that we do, and here there may be a little Some people may think the numbers that our research shows, maybe 4 or 5 ablations. Now, those are lifetime ablations, and these are ablations in a year. And that's where the difference is. But it's 2 ablations is right there where the sweet spot is, according to all of the articles. And with that, more importantly, what are the kind of outcomes we are showing? If you look at the CEAP levels and you look at how we are doing at 1 year with VCSS and CIVIQ scores, we're really delivering very, very good care throughout those 100 centers, guys. And again, can't thank Team CVR enough for doing that. Also, we are proud of the fact that we are providing complete vein care in most of our centers. There are certain areas where we still have to expand to provide this service, but as was again mentioned, whether there's obesity or whatever other multifactorial processes are going on, taking care of deep venous disease is as important as taking care of the superficial venous disorders. And we are very, very proud to state that our team is providing complete venous care. Now, let's come to what has gotten us to this stage with the presentations today. Dr. Pappas has been, since he joined us a few years ago, he's been leading our research and medical education program. And again, we'll touch on this in some of the subsequent slides as well, but along with his assistant program directors, Dr. Pappas's fellowship program is training more fellows in venous insufficiency than any other fellowship in the country. And also when we go on to what our research program is doing, and I again want to remind everybody, yes, research is done at one level, but all the data is collected at source by every one of our physicians. And consequently, what our research program has done is it's contributed more to the literature in the last 2 years than any other institution in the country. And yes, guys, that includes the academic institutions. It's something that each and every one of you, from the nurses out there who are doing all the data entry, the vascular techs who are taking those extra 10 minutes to record all the numbers, you all need to be so proud of. The research committee is working day and night, on Fridays, Saturdays, Sundays, to put these publications out there, and you see the outcomes. The last session of this program that was there, all that is data generated by CVR that will make the world look at morbid obesity differently. All the MEDCAC issues, one by one that were identified, they are being answered so that people cannot just challenge the credibility of the whole field of venous insufficiency. And all this is possible, all our dreams are possible because of an amazing group of physicians that we have. And I, again, just cannot thank every one of you enough for what you do day in and day out. Now, obviously, last year was a challenging year for all of us. And, for some, a little more than others. Some of us were fortunate enough, like, people here, and I'd put myself as one of the ones very, very fortunate because, I had the luxury of a team like this to help us. These are the 8 other engines I talk about that we all, and if I was thinking about an analogy, since a lot of the people in the audience are physicians, that it's almost like you're operating on a patient with an aortic dissection, but you have the best possible anesthesiologist right there. Once you're done, you have the best possible intensivist out there, you have the best possible perfusionist out there to help you through this. And ultimately, even that becomes fun, right? The patient is doing well at the end of the day. You do spend all the time that you need to spend to take care of things, but the camaraderie, the team spirit there, it's just this room where we'd be sitting, and obviously we took all the precautions that we had to take, but trying to decide what next. There's the finance team that's constantly churning out new budget numbers, because ultimately we got to make sure people are getting paid during this process. We had to put a fair number of people on furlough and still maintain their health insurance. The whole furloughing process, we had an amazing VP of HR who could just handle that. Our sales team, despite their best efforts during that time, I mean, the world is going through such a crisis, there's no way we can go out and meet referring physicians. So the marketing team kicks in. We get into telemedicine overnight. We are doing all the different marketing strategies overnight. Our, the IT team, which again, the unsung heroes always, they've got to bring everything together. The ops people, they're trying to, okay, today in this state, you're allowed to do something, and in this state, you're not allowed to do anything. How do you move people, yet all your staff is insecure, right? This hit the base of the pyramid, the Maslow's pyramid, that it hit our security level. We all felt insecure. How do you maneuver all that without a team like this? So guys, thank you very much, everybody, for getting us here. And for those of you who in the audience are considering joining a larger organization, this is what CVR brings to you, this kind of expertise, this level of expertise. And because of this level of expertise, despite the adversity, we continue to grow in 2020. These are all the new centers that were opened in 2020. And it's just amazing that through all that, our growth team continued to stay in touch with all the physicians, find new locations, and this was amazing. And this is the group of physicians that we partnered with. And if you don't recognize the names here, believe me, you don't know enough about the field of venous insufficiency. Dr. Schul, our past president of the American Venous and Lymphatic Society, all the other physicians here, we are very, very grateful for you all to have chosen to dream together with CVR, and we're very thankful for that. So guys, this is still our final target, right? For 2025, this is where we've got to get to. And we talked about this in our vision meeting last year. Our target remains the same, but to get there, what we got to first do is get to 100% in 2021. 2020 was a challenging year, but we now have to all decide, how do we deal with this new phenomena called the virus that's amidst us? And I have a little personal political statement to make here, that we have to beat this virus. We have to, in that whole thing, the fear of this virus, we have to beat. And now amongst us, we have an amazing solution, the vaccine. It's, and for healthcare providers, this vaccine has been made available. Almost all of our physicians now have taken the vaccine. This has been offered to a lot of CVR's patient providers who have patient care or patient contact. And some of us are refusing to take it. It's obviously ultimately a personal decision, but having gone through various continents and been exposed to multiple cultures, I'll tell you, the best in humanity comes when we feel our glass is full. When, as human beings, we start feeling that our glass is half empty or not full, we turn into animals. So it behooves us to get our economy going again so that we all can continue with, improving our societies, our families, our countries. And the solution is right there, which is, let's all take the vaccine, get over this fear, and do the best we can for our country and for humanity. So thank you all. Thank you very much for taking the time to be here today. I am sure you're all enjoying the amazing presentations that Peter has put together. And a part of the privilege I have today is we started this a couple of years ago, that we have a President's Award that we give to a physician who, for every year, and the physician, the criteria are the physician should have been with us for a few years and has done the most for CVR, for the mission of CVR, and we use the word for the glory of CVR. And our mission always has been to provide the best possible care to our patients in a compassionate and cost-effective manner. And a part of our vision is constantly, enhancing research and medical education. So, we have a whole committee of people who votes, and the unanimous choice for this year was Dr. Peter Pappas. And I'll tell you from my standpoint, it's, when you're trying to build an organization, you've got to say, okay, for a healthcare organization, first and foremost, we've got to say, okay, guys, we've got to have absolute clinical credibility. Next thing comes is we got to be financially viable and stable. Now, once those two things are there, to get into the next orbit, and somehow whenever I think of Peter, I just think of, he took us to the next orbit. And that next orbit is academic acceptance. We have to be out there where we are at par with any other place with respect to research and medical education. And these two things require a lot of giving. Clinical work requires giving too. We all work hard, but we get paid for it. Teaching, if you go back and think of your teachers, people who really impacted you after your parents, the next big thing is your teachers. And it's, even though the result is there, the reward is there, it's pretty delayed. It's when people grow up and you go back and you meet your teachers and you bow down to them in reverence. But for that time, you think of the teachers who taught you surgery. I mean, it's just, they're amazing people. And Peter embodies a teacher. Peter embodies a researcher. Look at how he picked up that these are the 5 points that Medicare wants us to respond to. And then it's like, it's not even days, it's like weeks of work that has to be constantly done. And I just feel CVR was so lucky to have met Peter, and thank you very much, Peter, for accepting at that time to join CVR. And I hope you are also proud of the presentations you're putting together today. Without you as a part of CVR, this would just not have been possible. And obviously, as a part of that gratitude, I also need to thank Heather, his wife, and Peter's lovely children, because I can see how all this takes him away from time that he could spend with his family. But that's how, we, as I said earlier at the beginning of my talk, that's the only way you can move science even a millimeter forward. So with that little introduction of Peter, I'm going to request Ken to say, our Chief Medical Officer, to say a quick word about Peter, and then we'll do a virtual award ceremony.
Thank you, Sanjiv. Congratulations, Peter. I will, for just like what Sanjiv said, this award is the highest honor, the highest achievement that any CVR family member can get. And I will tell you that nobody deserves this more than you. We're getting just a little bit of an echo. So in past years when we've done this, there's a lot of fanfare. We usually do this in DC, and we have the entire company come in, and confetti comes down, there's the band playing, and everybody in the entire company stands up and gives an applause to the President's Award member. And the biggest regret that I have this year is that we cannot do that. So what I'm going to do is I'm going to ask that Antoinette, if you could unmute everybody on the panelists at least. And then for those who are at home who cannot be unmuted, please send an applause to Dr. Pappas virtually so that he gets all of the love from our practice to him. So,
Woo!
We love you, Dr. Pappas.
Yeah, Peter.
You make the world go round.
Woo!
So again, just like what Sanjiv said, the tenets of the President's Award, the core tenets of the award is the conviction that the patients always come first. The second core tenet is work harder than anybody else, sacrifice more than anybody else, and Peter, you have done that. And then obviously from a research and data standpoint, evidence-based medicine, which is what you have brought to us. And then the last tenet, and again, there is no obvious order other than the patients always come first. Work hard, have fun, and you did that this year. And thank you very much for everything that you do.
Yeah.
So normally, as part of the award, there's a plaque that that will be sent to you. There's two plaques. There's one in the corporate office, which has all of the names of the previous President's Award winners. And then you will have your own sent directly to your house as well. And then probably the more meaningful award is that every President's Award member has received a star named after them. And that star started off with Sanjiv, and Sanjiv was the concept behind it was we wanted to symbolize the visionary that Dr. Lakhanpal was. We wanted to honor the person who had the vision of what a great medical practice could be. And then every President's Award member since then has gotten that honor of having a star named after him. And Peter, you will have your star named after you, and that certificate also is on the way to your house as well. But congratulations again. Thank you very much for everything that you do.
Yeah.
We'd love for you to say a word on this.
So thank you very much. I'm inordinately humbled by it. CVR, I feel, has given me more than I've ever given them. And just to put this in a little perspective, I joined CVR in March of 2016, so I'm coming up on my 5-year anniversary. Prior to that, I was a chair of surgery in Brooklyn, New York. So I was commuting 3.5 to 4 hours a day, working 70 to 80 hours a week. And I was doing non-venous related research. And as you all know, my heart is in venous disease. By joining CVR, I no longer have a 4-hour commute. My family gets to see me a little bit more. I don't have to worry about that carotid stroking in the emergency room or that distal bypass going down or the aneurysm rupturing anymore. And I get to focus on my passions in life, which is education. I love having the fellows. I love doing the research and working with my colleagues. And I really feel that CVR has given me more than I've given them. So I'm very humbled by this. Thank you so much. Thank you for the star. That was a wonderful gesture to make. And, you know, what more can I say other than, you know, it's time to move on to the next part of the meeting. So thank you again, everyone.
Thanks, Peter.